Welcome to this session of MD310 Medical Care Provider. In this session, we'll be discussing abdominal trauma. By the end of this session, you'll be able to identify 4 commonly injured abdominal organs, list 5 signs and symptoms of a severe abdominal injury, and describe and perform the care for a patient with a significant abdominal injury. So let's briefly review the anatomy of the abdomen. Remember, you're looking just at topographic anatomy, so you're looking at the lower level of the rib cage, the umbilicus, and the upper level of the pelvis and the pubis, that's the lower level of the pelvis, to define your topographic anatomy. And you need to remember where the lungs lie under that. Now, of course, what's where will depend on where you are in the respiratory cycle, with the diaphragm flattening almost to the nipple level on complete exhalation and going almost all the way down to the umbilicus or belly button on inhalation. But looking at this diagram here, you can see that predominantly in your right upper quadrant, you've got the liver. In the midline upper abdomen, you've got the stomach and the transverse colon, the large bowel where it crosses. Hidden behind those is the pancreas. In the left upper quadrant, you've got predominantly the spleen and the bowel. In the retroperitoneum, behind all of these, you have the right and left kidneys. Moving to the midline down almost into the pelvis from the upper and the lower quadrants, you've got the small bowel. It's kind of everywhere. In the periphery, you've got the ascending colon on the right, going from the right lower quadrant to the right upper quadrant, then crossing the midline and transverse colon, then descending again on the left side as the descending colon from the left upper to the left lower quadrants. And in the suprapubic or midline region in the pelvis itself, you've got the bladder. In females, you have the uterus. Behind that, you have the rectum at the last part of the colon. And so these, by knowing where these structures are, you get a general sense of what can be injured with a specific mechanism of injury. So abdominal trauma, of course, can be blunt or penetrating. Can also get burns and chemical injuries, but again, we're focusing on physical trauma here that we're going to see, the blunt and penetrating trauma. And the findings may be really obvious. They may have exsanguinating hemorrhage, blood just gushing out from the abdomen. That one's not subtle. They may have prolapsed bowel. The bowel may have herniated through the abdominal wall and be laying on the outside. That's not subtle either. However, findings may be very subtle or delayed. So maintain a high degree of suspicion. Someone who has suffered abdominal trauma, just like patients with abdominal pain, this remains the cavity of mystery, and sorting out what's going on can be a real challenge. So reevaluate, 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 check them again and again and again. Vital signs and physical exam. If you don't have an obvious finding up front and they've had abdominal trauma, you're just sort of waiting for the injury to show up. We had a kid when I was a resident who was admitted to the pediatric intensive care unit. He'd been in a high-speed motor vehicle crash. He had abdominal wall bruising. We'd done the full evaluation, CAT scans, everything, no findings. And about 24 to 48 hours later, he started to develop a fever and his abdomen became very rigid. And it was because he had injured his bowel. We couldn't see it on the CAT scans. It was bruising, and eventually that bruising led to enough bleeding that the bowel started to leak, and he had to go to the operating room to have it repaired. So you just need to be really suspicious, and any changes are red flags for you. Evacuate these patients early if you have a high degree of, if you're very suspicious, you have a high degree of suspicion that based on the mechanism of injury there was a significant intra-abdominal injury, or if you're going to be going into a situation where you're not going to be able to evacuate them if they do get sick, you want to consider evacuating them before you get into that situation. Any abdominal trauma patient, your initial assessment, body substance isolation, scene safety, make sure nothing's going to kill you, control exsanguinating hemorrhage, assess and manage the airway, breathing, circulation, assess them neurologically. An abdominal injury can injure the spine, and you can end up with lower extremity injuries. In addition, an abdominal injury can injure the aorta, the big blood vessel that runs from the heart down through the abdomen. We had a case at one point when I was in residency of a young man who had an ATV accident and came in with his lower extremities paralyzed. And it turns out that the injury wasn't to his spinal cord per se. The injury was to his aorta, and the blood vessels from the aorta that fed the spinal cord were injured, and so he couldn't get blood to his spinal cord. So that was what had caused his paralysis. You need to expose them and then protect them from the environment and find clues as to what's going on. And things you may need to do immediately: you may need to control bleeding, you may need to give them supplemental oxygen through a non-rebreather, and you may need to support their ventilation with a bag valve mask device. If you're not finding any immediate life threats on your initial assessment, and then you do your exam, you do your focused history, you get your vital signs. If their respiratory rate's fast, if their heart rate is fast or slow, or their oxygen levels are low, those are all red flag findings. Do your inspection, looking for swelling, tenderness, burns, lacerations, deformities, contusions, abrasions, penetrations. Any of those are concerning. Prolapsed bowel, bowel on the outside of the abdomen, bad sign. Any bruising around the flank or around the belly button, those are signs of internal bleeding, also bad signs. On exam, palpate the abdomen. If there's tenderness, particularly if there's percussion tenderness or rebound tenderness, that is signs that the peritoneum is inflamed. That's not good, because that's usually blood or ruptured bowel with bowel contents leaking into the abdomen doing that. Deformities to the abdomen. So any changes in contour after an injury, those are bad signs. Or guarding, where the abdomen is rigid, the muscles are rigid. Auscultation, not hearing any bowel sounds at all, that's problematic. Even if there's not a significant injury, the fact that you don't hear bowel sounds means that they may have what's called an ileus, a traumatic ileus, where the bowel's just not squeezing and they're not going to be able to tolerate anything by mouth. And then any bleeding from the bottom, from the rectum, or any vomiting blood, those are bad signs in trauma. So here's the key to all this. If the patient's sick, you really don't care what the injury is. You have got to get rid of them. So if they have a rigid or tense abdomen, their blood pressure's low, you see an open wound, you see bowel, they're vomiting up blood, or they've got blood from the rectum, there's blood at the end of the genitalia, or any other findings of shock, those patients are sick. You do not want them shipboard. What they need is bright lights and cold steel. They need someone to open up that abdomen and plug the dike, stop the bleeding, and you are not going to be the one to do that. So get them out of there. Even with your sick patients with abdominal injury, the things that you can do are so minimal, you really don't want them there. And we'll talk about the things that you can do, but it's very minimal interventions you can do other than to recognize that they're sick and get them out of there. Now, this is just a general guideline, and again, it really doesn't matter what organ is injured if they have findings that tell you that the patient is sick, but this is kind of nice to be able to predict what might be injured. So if you think about the mechanism of injury, where the injury is, if it's a right upper quadrant injury, the diaphragm, the liver, bowel in that area, and the kidney have the most potential to be injured. Again, there's lots of crossover. Other things can also be injured, but those are the most likely injured organs. In the epigastrium, in the upper midline, the diaphragm, and the pancreas. The stomach also, quite a bit of it lays in there, as does the esophagus, the food pipe, and that can be injured. In the upper left, the diaphragm, the spleen is your big one. Good part of the stomach lies up there, bowel and kidney as well. Lower right, lower left, and in the midline and the suprapubic region, you're thinking bowel or bladder. So as we're thinking about penetrating abdominal trauma, we're thinking about the open wound of the abdomen. This is a source of infection because now we've got the outside world able to get to the inside world. There are internal injuries, and again, if you think about penetrating trauma, as we've discussed in principles of trauma, most of the injury is going to come from the penetrating object itself. There's not necessarily going to be a lot of high energy transfer to other tissues, although if it's a gunshot wound, that may not necessarily be the case. And on your exam, you may see an open wound to the abdomen. There may be an impaled object or the bowel may be prolapsed or on the outside. So here we've got a patient with a penetrating wound to the abdominal wall, a large piece of wood that clearly, if you had this finding, would be very concerning. Here's another penetrating injury, this one to the rectal area. You can see from the x-ray that the stick actually penetrates quite far into the abdominal cavity. On the left, this is your only physical finding. But again, this is going to be very concerning if you see this, and you're going to want to evacuate that patient. This one may be a little bit more subtle. This is a stab wound. You can see the puncture wounds externally, and what the x-ray is showing is if you look on the left side, you're looking at the left part of the diaphragm, you can see the heart and the lung, and then you see a white line on the left with a little bit of black underneath it, and that black underneath it is air. So that's air in the abdominal cavity where it shouldn't be, and that can come from the puncture wounds themselves or from injury of one of the hollow organs, the bowel or the stomach. This would be a little less subtle, but certainly a finding. This is penetrating injury to the abdominal wall, and this was a shotgun actually, and then the bowel herniated through the injury, and this is what you're finding on a physical exam. So how do you treat these abdominal injuries? Well, for penetrating injuries, keep in mind, how did the penetration happen? If this was person-on-person violence, scene safety, that last little bit of sharks, human and otherwise, who are trying to kill you, becomes critically important. So you need to assure that your scene is safe. Body substance isolation is also key. These are very, very bloody injuries. For the patient themselves, X, A, B, C, D, E, F, control any exsanguinating bleeding, airway, breathing, circulation, neurologic injury. Think about that rectal penetrating injury with the stick. That could easily have injured the spine as well. Expose them to find all their injuries. If you don't expose them, leave them in their coveralls, you may not find the bowel that's prolapsed through the abdominal wall, and find other clues as to what's going on. Stabilize any impaled objects. You may need to cut them to extricate the patient or move them, but don't remove the impaled object. I took care of a patient at one point who tripped and fell on rebar. He was working in a basement. He fell on the rebar, penetrated. It actually went right through his umbilicus, so you could really not even see a wound. And his friends grabbed him and pulled him off the rebar. He was flown to us. He actually had normal vital signs except for a very slight tachycardia, heart rate of about 110 during the flight. He was a young, healthy guy. He got to us, and his blood pressure had been fine throughout the flight. We got him into our trauma room. We started to resuscitate him, and within 3 minutes, his blood pressure had dropped to 70 systolic, and he became diaphoretic and pale, and he looked terrible. And we basically rushed him to the operating room. There was nothing else that needed to be done. He had IVs, he got fluids, we ordered blood, but we got him to the operating room, and when they opened him up, the rebar had penetrated through his bowel, but had actually gone between the aorta and the vena cava and injured both of them. And how he'd not bled to death when they pulled that out, I don't know. It's unbelievable. He managed to contain that bleeding, but had the rebar been cut off in place and left there, he would not have crashed the way he did when he got to us. And that was only an hour after the injury, so think about what would happen shipboard if you've got 3 or 4 hours till you can get the patient evacuated and you pull out that rebar. They're going to die right there. So leave the impaled object in place. Cover the wound. If the bowel's prolapsed, moisten a trauma dressing, or if you don't have a trauma dressing, moisten a towel, put that on, and then cover it with saran wrap or something that's fluid impermeable to keep the bowel moist so it doesn't dry out. And then you want to talk to medical control. They're going to need IV fluids. You're going to need to control their pain, antibiotics with an open wound, and get them evacuated. So when you think about blunt abdominal trauma, you don't have the obvious injury necessarily, but you've got to remember that the blunt force gets transmitted to the underlying organs. Now, if your patient's sick, who cares? And you really don't need to know which organs are injured because they're sick, something's broken, they need a surgeon who can cut open their abdomen and find what's broken and fix it. But if they're not sick and you're going to be monitoring them, you can use the location of the injury and your knowledge of the anatomy to predict what you need to be concerned about. So for example, a patient stumbles, falls, and strikes their left flank against a railing, and they're having some pain there. The rest of the abdomen is unremarkable. Well, you're thinking, geez, left flank, good chance there's a left kidney injury if anything's injured. And so what can you do? Well, you can get a urine sample and look for blood in the urine, or dip it for blood. And if you find blood, that tells you that there is an injury to an underlying organ and you need to evacuate the patient. So your knowledge of anatomy can be helpful in assessing a patient who otherwise appears well, because it gives you a direction for how you should do further assessment. And the same with someone who's suffered an injury to the left lower quadrant. They were struck in that area, and you're not necessarily finding anything. Well, the first time they move their bowels, if there's blood in their bowel movements, that's a really bad sign and they need to be evacuated. So this is a patient who was involved in a high-speed motor vehicle crash. You can see that there was, looking at him, quite a bit of trauma. He was passenger side, he was T-boned on that side, and you can see the bruising, you can see where the injury is. And this is only a few hours out where you're already seeing this amount of bruising. So that's pretty concerning. If you look at the CAT scan, you can see on the right side there's an area just under the skin that's bright white, and that's blood in the abdominal wall. That's the contusion, and you would predict underlying injury from that. So treatment remains the same. First, protect yourself, then control any exsanguinating hemorrhage, airway, breathing, circulation, disability, expose and protect, and find other clues, and then talk to medical control. And if you have any findings that they're ill, or your mechanism of injury is highly suggestive, or they don't appear ill, but you come up with a plan for monitoring them, and then something comes up like blood in the urine, you want to evacuate them. In the meantime, IV fluids and pain control, not a lot else that you're going to be able to do, but keep them stable. And as you're giving IV fluids to trauma patients, your goal is to give them enough fluids to keep their blood pressure, systolic blood pressure, between 80 and 90. The only exception to this is head injuries, where you'd like to keep it above 90. But for the rest of your trauma patients, we do what's called permissive hypotension. You give them IV fluids to keep their blood pressure between 80 and 90. That way, they have enough circulation that they get end organ perfusion, they get flow to their organs, but you're not putting so much pressure in the system that any clots that they form that help to stop the bleeding get washed out, because that can happen if you give them too much IV fluid, return their blood pressure to normal. You put so much pressure on those clots that they start leaking again and the patient starts bleeding again. Please complete the knowledge review for this session, and if you have any questions, please contact your professor or instructor. Thank you very much.